Good afternoon and welcome to the 2014 CAQH Index, Adoption Rates and Cost Savings from Electronic Administrative Transactions. My name is Karen Waller. I am the Director of Communications and Marketing at CAQH, and I'll be your moderator this afternoon. Just a bit of housekeeping to start. To participate in today's session, your phones will be muted throughout the presentation, but at any time throughout the session, you can communicate a question to us through the web. All you need to do is go online to the Q&A panel on the right-hand side of the GoToWebinar screen, type in your question, and we will address the questions at the end of the session today. Also, following today's presentation, you'll be able to access the presentation on our website, CAQH.org. It may take a few hours to get it up there, but you can look under the CAQH Index tab. You'll see both a PDF version of the webinar and also a recorded session as well. Let me introduce today's speakers. First is Jeff Lemove. He is the Research Director at CAQH, and he'll be leading today's presentation. We also have with us Andrew Naugle, Principal and Healthcare Management Consultant from Milliman, Inc., and also Gwen Lowe's, who is Deputy Director of CAQH and also the Core Managing Director. At this, I'll turn it over to Jeff. Jeff?
Well, thank you, Karen, and thank you all for joining us. We're really excited to be releasing the 2014 CAQH Index report. And today's webinar will go through the basic findings. As always, there are more details in the report itself, which is available now at caqh.org. And feel free to contact me if you have questions that aren't addressed in today's webinar. My information will be at the end of this presentation, and it's also available on our website. So to start off with the agenda for today's session, we'll give a little overview of CAQH and a little bit of background on the index and why it matters. And then we'll go through the findings of the index. The three main topics are the cost savings that we've estimated this year, the adoption rates for electronic transactions that we have found this year from our data, and interesting changes in transaction volumes that we picked up. By this being the second year that we've done the index, we're able to track some preliminary changes. Then we'll go to participation in the 2015 index, which is now starting. And I'll go through a little bit of information about how both health plans and healthcare providers can help us gather even more and even better data for 2015 and what you get out of it. And then we'll close with plenty of time for question and answers. And like Karen said, please submit those at any time through your panel. So first with the CAQH overview. As most of you know, CAQH our mission is to streamline the business side of healthcare. And to do that, we set up collaborations between health plans and healthcare providers. We have many programs that are designed to create innovative ways to accelerate the transformation of business practices and thereby deliver value to providers, patients, and health plans. And specifically, some of our initiatives include COB Smart, which is a way of streamlining the processing of coordination of benefit claims. CAQH's new ProView, which is a way of consolidating provider information in one place. Similarly with Enroll Hub, which allows healthcare providers to sign up for electronic funds transfer in one location that's centralized and not to have to do it with every one of the health plans that they contract with directly. Gwen is here today. She's the director of CAQH's Core project, which sets up industry consensus processes to determine and create operating rules to make the HIPAA standardized transactions more robust and workable, and so on. And then the index is a CAQH project to track our process toward increasing the use of electronic transaction processes. So what is the index more specifically? It's really about tracking the transition. We've described in the 2014 index report this quiet but important revolution of moving from manual toward electronic administrative transactions. And these include several measures that I'll get to in just a second. And one of the types of transactions that we focus on are the HIPAA standardized electronic transactions, but we also track all varieties, including transactions done by phone, fax, snail mail, email, interactive voice, and web portals and other means of communicating between health plans and healthcare providers. In addition to measuring the adoption rates for electronic transactions, the index data gathering process also helps us create cost estimates of the savings from continuing the transition to fully electronic transactions. And our methods are guided by our advisory council, the CAQH Index Advisory Council, who are experts in claim-related transactions and business practices, and they represent health plans, healthcare systems, and provider practice groups. Why is this so important? Well, what we found through the index and what we know is that converting from manual back-office business transactions toward electronic transactions cuts costs. And reducing unnecessary healthcare administrative costs is extremely important to health plans. And it's extremely important to healthcare providers to ease the administrative burden and require less staff time on administration. When information is communicated quickly and easily and directly, errors are reduced and follow-up costs are reduced, and that reduces the friction between providers and health plans all around. And then finally, and I think interestingly, we've heard a lot about the conversion of the clinical side of healthcare from paper charts to electronic systems. And the electronic business transactions that practices and facilities are using are sort of a complement that goes along with that to create a fully electronic healthcare information environment. So for the CAQH Index, where did the data come from? Well, our data comes mostly from health plans serving the commercially insured population, and that includes Medicaid managed care and Medicare Advantage or managed Medicare enrollees. The total number of enrollees represented by the health plans submitting their data is 112 million, and the total number of transactions studied this year totals more than 4 billion. The data for the 2014 index that were collected in 2014 are for the full calendar year, January through December 2013. CAQH collected data from health plans, and our consultants at Milliman also collected data directly from healthcare providers to help us assess their providers' costs of electronic versus manual transactions. And as I mentioned, or as I hinted, the 2014 index is our second year doing this report. The 2013 index was our baseline, and we have data for the 2013 index was for the full year 2012. And so having 2 years of data now from plans reporting in both years, we're able to create year-over-year comparisons and preliminary trends. So what transactions did we study? Well, the 6 main transactions were studied in 2014 and were also studied in 2013. And they are claim submission, eligibility and benefit verification, prior authorization, claim status inquiries, claim payments, and remittance advice, or explanation of payments, explanation of benefits transactions. In addition to those 6 main transaction studies, we also in 2014 began collecting data on attachments, both claim attachments and prior authorization attachments. And although we don't include estimates from potential savings on attachments in this year's report, we did collect preliminary data finding that there were over 100 million attachments sent in 2013. And therefore, we believe this is an area where increased electronic transactions could potentially save a great deal of money. Just to give you a preliminary preview for 2015, for the 2015 index, which is now being launched, the Advisory Council, the CAQH Index Advisory Council, is considering several additional transactions, including breaking out a coordination of benefits claims, also including a referral certification or permission transactions, and also for the first time studying transactions that aren't necessarily claim-related. For example, the transactions that are mostly between health plans and employers for enrollment and disenrollment, and also for premium payment. These are also transactions that could be made electronic and therefore more efficient. So to get right to the bottom line, the cost savings that we estimated in this year's report from the 6 main transaction studies, claim submission, eligibility and benefit, prior auth, claim status, claim payment, and remittance advice. We estimate that the total savings available just from changing those transactions to purely electronic is about $8 billion for the entire industry. Most of those savings would go to healthcare providers, and I'll explain why that is in a little bit. But we estimate that there's still plenty of room for savings on the plan side as well, with over $1 billion in estimated savings for just these 6 transactions alone in the 2014 report. There's really 2 sources of the savings. The main reason for the savings is, number 1, that there are still a lot of manual transactions that could be converted to electronic. And number 2, there's a big difference in the costs of manual transactions versus electronic transactions. Slide 12 shows sort of the detail, some of the detailed data that we gathered this year on transaction costs for both health plans in the left column of data and healthcare providers in the middle column of data, and the industry, which is just the health plans and the providers combined, in the right column. Although there's some differences from transaction to transaction, the simple average of all the transactions, all 6 transactions, for health plans, the manual average cost was about $2 per transaction. But for electronic, the average cost was about 5 to 10 cents per transaction. For healthcare providers, we estimate the manual cost was about $5 per transaction, and the electronic cost was a little bit over $1.50 per transaction. And the way to read this chart is, for example, if you go down to the rows highlighted in red, claim payment, go over to the center column for healthcare providers, you can see that we estimate that for receiving a claim by check, we estimate that that costs a healthcare provider a little more than $4 to process that check, and for if that were done with electronic funds transfer, the total cost of handling that in terms of the infrastructure and the fees and whatnot would be a little over $1. So that's where the savings come from. The second part of where the cost savings come from is that there are still a lot of manual transactions out there. And chart 13 shows sort of an example of how different transactions have different electronic transaction rates. If you start from the rightmost column on this chart, you can see what we call our industry average, or plans and providers combined electronic transaction rate. And you can see that for some transactions, such as prior authorization, we're estimating an industry average electronic transaction rate of only 35% for prior auth, but as high as 92% for claim submission. And you can see, if you move one column to the left for transactions that we consider electronic for healthcare providers, an even broader range from as low as 7% for prior auth to 92% for claim submission. Now, how does the math on this work out? We'll move to slide 14. We track all sorts of transactions, and some of them we consider fully manual, such as sending a piece of paper and receiving a piece of paper, or sending a fax and receiving a fax. Some of them we consider fully electronic, such as the HIPAA standardized transactions that are done in an automated fashion through the IT systems of health plans and healthcare providers. And then some of them we consider electronic or automated for health plans, but manual for healthcare providers. And these are methods of handling transactions such as web portals, where a provider would enter data and it would get a response back from the plan's web portal website, or interactive voice response, where a provider would dial up a number and get a response. And in those cases, we consider that a manual transaction from the provider side, because they're putting in data for each individual transaction, non-automated, but it's automated on the plan side. This is why the electronic transaction rates can differ between health plans and healthcare providers in our estimates. They don't differ on every category. For example, for claim payment and claim submission, the percentage of electronic transactions is the same, because a claim payment can be either on paper by check or it can be through electronic funds transfer. Same with claim submission. It's a paper claim or it's an electronic claim. But for some of these other categories, like eligibility and benefit, prior auth, claim status, we have these partially electronic transactions, which are considered electronic for the payer, for the plan, but not for the provider. When we hone in on the fully electronic transactions, which we think are the most efficient, we can look at both 2012 and 2013 to see what the trends are looking at. And from companies that responded in both years, these are the transaction rates for these 6 transactions for both years. And as we can see, in most cases, there was a modest increase in the fully electronic transaction rate. For example, in the highlighted section there for claim payment, you can see that electronic funds transfer was about 50% in 2012, about 57% in 2013, and some smaller increases for some of the other categories. There was no data sufficient to make this comparison for prior auth in 2012. So in addition to there being still a lot of transactions that have fairly low electronic transaction rates, we also discovered a wide range of adoption rates even among the companies that responded. On chart 16, this illustrates some of the ranges or the variance in electronic transaction rates that we got between responding health plans. For example, for remittance advice, explanation of benefits, on the rightmost bar there, the average rate of fully electronic transactions, or the HIPAA standard for that was 47%. However, some plans were up in the 70% range, and others were down in the teens. So you can see that there's plenty of room for improvement, not only in getting whole transactions moved up toward 100% electronic, but also among different health plans. Some had higher and lower rates for individual transactions. And so the health plans that respond to our requests for information receive this information, and they can see how they stack up against other similarly situated health plans. We also provide breakouts, and slide 17 gives an illustration of sort of an overall benchmark breakout that we would provide. For example, showing in this case multi-state health plans versus large single-state plans, which are mostly Blue Cross and Blue Shield plans, on simple measures like number of claims or eligibility and benefit verification transactions per member per year, and so on, to get an idea of the scope of the data that we're seeing. One of the key things that we've been able to get from plans responding in both years so far is year-over-year change. And chart 16 shows the results that we're seeing on that. In the highlighted box area there, you can see eligibility and benefit verification and claim status increase have had a big increase in the HIPAA standardized transactions. Not much decrease in manual transactions, and an increase in web portal and IVR transactions at the same time. And the report goes into reasons that our responding plans gave for why this would be the case, having to do with the implementation of new rules at the beginning of 2013, and also having to do with changes in the marketplace. The report provides some context and some illustrations for the various rates of year-over-year changes that we saw in this year's index report. As part of the process of gathering data to make cost estimates for the entire industry, we estimated how many overall transactions are still being handled manually for these 6 main transactions. And for health plans, we estimated that there were about 1 billion still being handled manually. And the way we did this is extrapolating from the health plans representing 112 million enrollees that responded to an overall universe that we estimate is about 240 million, 245 million total enrollees in commercial coverage. On the healthcare provider side, that extrapolation leads to our estimate of about almost 2.5 billion manual transactions still taking place when we extrapolate to the entire commercially covered population. So at this stage of our presentation is where we ask you for help. Although we have health plans representing 112 million enrollees, we would like to boost that and boost it as much as we can. And we will be advertising the new specifications for the 2015 index in the coming days, and we encourage you to take a look. They're already actually available at CAQH.org. We believe the need to streamline healthcare administrative transactions remains urgent, and data tracking of our progress is a key component of making progress, so companies can benchmark against what other companies are doing and make improvements. And part of the CAQH ethos is trying to create a sustained effort from health plans, vendors, clearinghouses, hospitals, providers, government, all stakeholders really, to continue to drive this transition to electronic transactions and achieve the value and return on investment as we make these transactions less costly, more predictable, timely, accurate, and uniform. And we'll continue to inform this process through the index. For 2015, we're looking for both healthcare plans and healthcare providers to provide data, and we'll be reaching out to more plans this year. Last year, we were very successful in attracting some additional Blue Cross and Blue Shield plans. We're hoping to attract even more this year to take advantage of the process of learning where you stand through the benchmarking process and providing data. Also with healthcare providers, the data that Milliman collected this year for us, and Andrew is on the line to help answer your questions on that part, was invaluable. They collected data on healthcare providers' costs per transaction, and we'll be looking to improve the number of healthcare providers responding and improve the accuracy of those results year by year so that we can provide you the best tracking and the best estimates possible over time. And the reasons for doing this, in addition to just supporting the industry's efforts, are to be able to have a look at how your company, how your organization compares with our benchmarks, and look at the specific potential for efficiency gains within your organization. And one tool that we've created to help with that is our CAQH Index calculator, which is also now live on our website today. And in this, you can type in estimates of the numbers of annual transactions in your organization and get back a result that gives you an indication of how much potential savings are on the table if all those transactions or a portion of those transactions were converted from manual to electronic. So as I mentioned, I'm Jeff Lemieux, and my information is there on slide 24. You can feel free to call us if you'd like to learn more and participate. I've gone through the highlights of the CAQH Index report fairly quickly. We'd welcome your questions either now for the rest of this webinar or individually if you want to ask or receive more information about participating or about the methodology and so on. And with that, I'll invite Gwen and Andrew to join me in addressing any questions you might have.
Thank you, Jeff. Again, if you would like to ask a question of our panelists, please go to the right-hand portion of your screen and type in a question, and we will ask them. We already have a couple that have come in. So when targeting, do you currently target health plan provider breakouts? So for example, do you have any information comparing medical specialties or perhaps carve-outs such as behavioral health or dental health?
Okay, great question. For the 2014 index, this report, we've broken out several different types of health plans, such as large multi-state plans versus single-state Blue Cross Blue Shield plans. And we've also created some preliminary breakouts between commercial coverage for the under 65 population and Medicare Advantage coverage for the private portion of privately administered portion of Medicare for the over 65 disabled. For 2014, those are the most detailed breakouts we have by plan. For 2015, we're making a push to have improved breakouts for Medicaid coverage and also for dental and possibly even vision. And we're working on those specifications now and recruiting dental insurers and other specialty providers to join us in the index for 2015. As far as types of providers such as specialties, we don't have any data at that level of detail at this point.
Okay. Thank you. Next question. There are several questions asking if we will be providing a copy of the presentation, and the answer is yes. That will be available later in the afternoon on our website, caqh.org, under the Index tab. We will post the PDF, and also early tomorrow we will have a copy of this webinar as well. So thank you for inquiring about that. Another question, what is the difference between claim payment and remittance advice transactions?
Okay, so the claim payment itself is either a check or an electronic funds transfer. The remittance advice is the statement or the explanation of that payment that accompanies it. The remittance advice can be sent on paper in the same envelope as a check. It can be provided on a health plan's member web portal. It can be transmitted through the 835 HIPAA standardized transaction. So the payment is the movement of the money, and the remittance advice is the explanation for why that payment and how it maps to a claim.
Thank you. A question, electronic 835s populated with adequate data offer a significant advantage to provider organizations. Do you know of any studies that have quantified this impact?
The studies that quantify the impact of 835s, the 835 is the number that corresponds to the HIPAA standard transaction for remittance advice. And I can defer to Gwen on this to some degree because the 835 is a complex form, and it's used to reassociate payments with claims. And Gwen, if you have some.
Absolutely, great question. And there is quite a lot of focus that was done during the second set of mandated operating rules around the data content in the ERA. And a lot of the data content in the ERA is the codes, the remittance and remark codes. So the industry itself, both participants in the operating rule effort, which is CAQH Core, as well as non-participants industry-wide public surveys, focused on improving the quality of and the standardization of that data in the ERA. On the remittance advice, you can go on to the website under Core and look at the EFT ERA operating rules, specifically the code combinations for the ERA. They're called CAQH and RARCs. And there's a whole process to take what was thousands of code combinations that were all combined differently by each health plan to now have a common set of code combinations across the whole industry where the definitions and the codes and the remarks are used in a similar manner because that content is so important. And we have received a number of entity-specific case studies as to the value of having that common combination and those codes used. And a lot of those, for instance, Emory Hospital just presented about their use of the CAQH and the RARCs and the impact on their provider health system. And you can go to the calendar, the CAQH calendar, and download Emory's presentation. So we have had a number of examples, and we would welcome others. And what we do is beyond the index, we then study ROI for specific rules, and we'll be studying the ROI impact for that particular rule on a national basis in the coming year.
Thank you, Gwen. What are the requirements for a plan to participate in the index? Is it a relatively simple data submission process, or is it are there complex data requirements?
It's relatively simple. What plans do is they receive a spreadsheet. There's an example up on the website now. It's called a data submission template. It's a spreadsheet with with different tabs, and you return aggregated data. For example, taking just the most straightforward one, claim submission. What the company would return is the numbers of claims that were submitted on paper and the numbers of claims that were submitted electronically, if possible, broken out by the types of breakouts that we've been talking about, Medicaid, Medicare Advantage, and so on. And that's a similar format for each of the transactions. So it's relatively simple. The harder part comes from getting the data itself. Some companies don't have the data easily at hand with their current systems, and they have to track it down. Many of the health plans that have worked on this year have gone back and forth. We've had calls to help clarify. We have a reporting guide that's intended to help clarify how the data should be pulled if necessary, if it's not on the shelf, to make sure that the data returned from each plan is as consistent as possible with the others. But the main requirement is enthusiasm and the willingness to work a couple of days. You know, some health plans, it's going to take a few hours to get this data submitted. Others, it's going to take longer, but it's always worth it. That we guarantee.
This is Gwen. I just want to add to that. There are slicks on the website. There's one page about if you're a health plan, if you want to participate, or if you're a provider and you want to participate, and they give an estimated range of hours based on our current participants and just the steps and links to the data collection tools that Jeff referenced. And as he also referenced, he has been an essential resource to those that are contributing. So you would absolutely not be on your own just given the tools. You would then have someone that would be readily at hand to walk you and your team through the process. But we've found that actually, you know, once you've done it, it's quite simple moving forward. We've kept all the, every single entity that contributed the first year are all contributed the second year, so it can't be that hard if they're all back there, and we've retained everyone. So please do think about it.
And as a corollary, there was another question: what time period or season of the year is the data due to CAQH?
Another great question. Thank you. We've just put the specifications for 2015 onto the website as a result of our advisory council call last week to finalize those. The timing for data collection runs essentially from now and through the end of May for plans that have already done this before. And for plans that are getting started, we sort of ran a little bit of extra time. The absolute drop-dead deadline for responses is July. Probably the very end of July would be the very last point we could accept new data. We do work back and forth with you. The way the quality control process works is we'll look at the data as it comes in. We'll go over it with you. We'll compare it against the benchmarks from other companies that are in an aggregated form, not individual companies, but the overall benchmark for that type of company, and troubleshoot. Look to make sure that we've identified the data in the same fashion according to the data submission guide. And sometimes that's a learning process that takes some back and forth before we get it right. And so it does take, we have an overall period of several months in order to get data because we know that some plans will be going to different departments and gathering data for the different transactions.
Thank you, Jeff. Jeff, you did note that the index is not currently looking at providers by specialty type. Are there any plans to do so by type of practice setting, such as institutional health system versus a physician practice? We hope so.
This is a great, that's a great question because it allows me to plug participation from the provider side as well. Andrew can elaborate, but this year Milliman helped us with the provider side data gathering, and they did a terrific job at gathering data from a broad scope of healthcare facilities, ranging from very large health systems with multiple facilities to individual facilities such as hospitals or outpatient groups to smaller clinical practices down to fairly small medical groups, to give us a good feel for the different type of healthcare providers that are out there. We did not collect enough data to really reliably break that out type by type, but we're hoping that for 2015 we'll be able to separate out some categories of healthcare providers, just like we are able to benchmark out some categories of health plans.
Thank you.
Andrew, did you have anything you wanted to add on that one?
No, I think as we increase the size of the sample of providers that are submitting data, we expect to be able to slice the data into other categories such as provider specialty type or other organizational classifications.
Next question. What percentage of these transactions are Medicare? If Medicare providers are 100% compliant with all these transactions as fully automated transactions, with the exception of prior authorization, doesn't this greatly exaggerate the statistics? And I assume we mean by that on electronic.
The great question. The only portion of Medicare that we're picking up is Medicare Advantage. And for many of the health plans, they were able to separate out their Medicare Advantage results because they're somewhat different. For example, there's nearly 3 times as many claims per member for Medicare Advantage as there are for the commercial under 65 population. But we do not, in the 2014 index, have data on the fee-for-service side of Medicare, the part that's administered by the government more directly. It would be nice to be able to get that at some point in the future, and that's on our target list. But for example, Medicare fee-for-service claims are not included in our aggregation at this point. It's just for our definition of the commercially covered population is the under 65 privately covered, plus the Medicaid HMO and the Medicare Advantage. And for 2015, we're also hoping to be able to break out dental and possibly vision. Just throw that in response to a previous question.
Another question asking about segmentation of the data. Do you know what region of the country demonstrates the greatest transition from manual to electronic processing?
Not yet. At this point, we're hopeful that we might be able to get regional breakdowns perhaps in 2015, perhaps in 2016. But this year's 2014 index, we did not ask for regional breakouts from our large multi-state plans. And we probably, we have quite a few single state plans in various parts of the country, but probably not enough to reliably do a regional analysis at this time. That's another thing that we're hopeful of improving on in the future.
A question, how do you reconcile the relatively minor differences or growth in the adoption of electronic transactions with a few slides later in which there seems to be more substantial growth in transaction volume?
I think that's just the the arithmetic of how that works. It's with the huge transaction volumes. I mean, you can sort of see like there aren't that many manual claim submissions at this point. And so if you go, I don't know if we can go back to that slide. Let's just describe it visually here, virtually. You can have large double-digit increases in the number of transactions that still only correspond to a few percentage points in the rate if the overall number of transactions is still increasing quite a bit, and the number of, say, manual transactions isn't falling all that much. And we did notice that, especially for eligibility and benefit verification, and also for claim status inquiries in 2015. So there were double-digit increases in fully electronic HIPAA standardized transactions, but there wasn't much of a decline in manual transactions. There was a big increase in web portal. So even though electronic transaction numbers went up by a large percentage, the adoption rate only went up by a few percentage points. I hope that was relatively clear.
And as a context, this is the data, it's a 2014 report, but it's data from 2013. So for the eligibility and claim status, for instance, 2013 was the beginning of the operating rules. They just started moving out in the industry. So for instance, real-time claim status was just becoming available. So we're very interested with this, the 2015 report, which will be 2014 data, to see where those trends are going, because there is no doubt that federal mandates and the impact on the adoption is something that we're looking at very, very closely.
Actually, that transitions into the next question. Have you seen, or do you believe that there is a relationship between increased adoption of electronic transactions and adoption of operating rules?
We've had over 50 entities on public webinars in the last year and a half tell us absolutely yes. They can directly show where the requirements for the operating rules, such as the availability of real-time access to eligibility, is allowing them to use the transactions more. on the provider side, or we mentioned earlier the question about the content for the ERA, where now that content is more rich because of the common codes. So now providers are using that to manage their revenue process more closely. So we absolutely are tracking and seeing that on a qualitative and also a quantitative basis. It is no doubt going to take some time. This is we're lifting an entire industry of billions of transactions. So sharing those best practices and then tracking the results is something we're committed to on a long-term basis.
Thank you, Gwen. For those transactions where the plan side is more automated than the provider side, how can we reduce the amount of manual work for providers?
So that's another excellent question. We are tracking both the manual as well as the partially manual for providers and fully manual for health plans, and then the completely standardized for both for a reason, is because we don't want it to be manual for the providers. That partially manual means the provider has to go to every single website differently. We want them to be able, as providers, to get the full benefit of all payer responses, standardized electronic, robust content, strong response time, strong error reporting. So as we're rolling out the transactions through the operating rules, we're going to continue to pinpoint where we most can have the impact to get the providers fully electronic. And part of that is what vendors do the providers use. So in many cases, some of the providers, whether they be large facilities like hospitals, or they be smaller providers, they may use a mix of vendor systems. And how, moving forward, the providers will need to be looking to see how do each of the vendor systems work in compliance with some of the federal mandates, some of the best practices. How do they use tools such as certification processes to ensure that both the vendors the providers are working with as well as the health plans are in compliance, and then therefore the providers are getting all of the benefits of this.
Thank you. Jeff, what portion of the respondents of health plans to the index were from Blues plans or regional plans?
Great question. That's answered in the report on Table 3. Of the total plans responding, there were 112 million enrollees. 17 million enrollees came from single-state Blue Cross Blue Shield plans. There were also enrollees that are part of the Blue Cross world, but that were considered part of the, the multi-state plans. There are some multi-state Blue plans, so there's Blue Cross representation in both the single-state and the multi-state category.
Are the only organizations that can participate in the index health plans and providers? Is there any possibility for clearinghouses or vendors to participate in the future?
The answer is yes. We would love to get information with and in cooperation with clearinghouses to help us validate what we're learning and also to get the data from a different perspective. And we don't have a solicitation or a data submission template. What we've envisioned is working out customized systems with individual clearinghouses that are interested. But we would welcome that opportunity and would encourage you to contact me if you have ideas on that.
And one thing we would absolutely do this year for those vendors that have their provider-facing vendors, we would ask the vendors to work with your users that are providers and collaborate with your providers to actually submit a provider data collection tool. We are, as Jeff had highlighted, determining how to engage the vendor and the clearinghouse community, but it's very important that these are objective data. So we want to compare apples to apples. So if you do have a provider, if you're a provider-facing vendor, working with them, or if you're a health plan-facing vendor after health plan, if they're participating, and then work with them to submit those two collection tools that we do have.
Another question about provider costs. Are there any details available in how the provider costs were collected? For example, how many minutes on the phone, how much staff time and materials, or is that perhaps available in the details of the index report?
You know, that's a question that I haven't really thought about, but those sorts of details were precisely how Milliman estimated the costs for transactions, by going through with the healthcare providers and learning their time spent on the phone for various transactions and estimating the cost of the staff working on those transactions in terms of their labor costs and so on. I hadn't really thought to break that out in benchmark for this year's report. I can turn it over to Andrew for thoughts on that, but that the answer is no, we don't have that for you in this, but that sounds like a very interesting idea that we could pursue.
We do have it, we just don't have it in the report. Great.
Andrew?
Jeff is absolutely right. That's part of our process for how we collect data from the provider organizations to really, and that's really key to ensure that we are getting the slice of a given transaction that's totally related to development of that transaction as opposed to ancillary activities that go on around the edges of these transactions. And so that's how we collect the data, and it's accurate that we do have it, but we've just not included it in the report.
Yep. And one other thing that we are considering doing with the report is highlighting things like that Andrew just went over, and then additionally, these are the direct costs for the electronic transactions, so things like labor. There's a number of indirect costs and indirect lost opportunities. So for instance, we all know provider bad debt, when they don't have the eligibility information at or before the time of service, is actually significant if they don't check eligibility. So we'll be looking at also the indirect impact, because provider bad debt can be reduced by 10 to 25% if the provider has access in real time to the eligibility information. Each of these transactions has a similar indirect impact that we'll be taking into account.
A follow-up question. The manual costs of claim payments and remittance advice to health plans seems very low, costing even less than the postage it would take to mail a check and an explanation of benefits. Are there exclusions to the manual cost calculations made by CAQH? Is there a reason for this low?
There's a reason, but it's not an exclusion. What we found is that many health plans send out their claim checks and explanation of benefits in bundles. So an envelope might contain checks for many, many claims and have several explanation of benefits included. And that bundling is why the cost of manual transaction can be less than the cost of a stamp when you go back and measure it on a per transaction basis.
The index tracks electronic funds transfer, which is mandated and a low-cost way to get payments, but some providers are being offered virtual cards. Does the report track these card volumes?
We did not find virtual card volumes in the 2013 data, but we expect that we will see that in our 2014 data when we do the 2015 index this year. We did ask our data respondents, specifically, did you not have any virtual card payments, or are you just not able to track them? And the answer, we got a little bit of both, but for the most part, it was very few virtual card transactions that we were able to find in 2013. But this will be a focus of our attention in 2014, and we think the numbers will be more. We think there will be estimates for that for 2014 in this year's report.
A question. Let's see. How do you reconcile that although claim status and eligibility were, quote, mandated in 2013, they don't approach 100% adoption and only show a minor increase over 2012 data?
So across the board for all of the HIPAA mandated transactions, which The 6 in the report right now that go both years are HIPAA mandated, and the ones that were added, which are attachments, are not mandated right now. For the HIPAA mandated, the health plans are required to adopt. So they were required to adopt the standards several years ago. Now they're required to adopt the operating rules, which add more content and require things such as real time. So we're starting to see an increase of these transactions as they continuing to become more useful. Clearinghouses are also required under HIPAA to adopt. Providers are not required to adopt, and neither are practice management systems serving providers. So you've got a system in which some are required to adopt, some are not, and then additionally, as we're moving forward, entities have old IT systems, so if they aren't required to adopt, they may be waiting a few years to change their systems, and that system's not up to date. So it's going to take a bit of a life cycle to reach the full levels that we want for adoption. And it's also going to take engagement from the non-HIPAA covered entities like the practice management systems. And that's why we talked earlier about things like having a seal, like the core certification seal, for all the entities to say they are in compliance, they have been tested, and then a community-based enforcement process where we're all building a system to say we need to meet these requirements, we need to drive this cost out of the system.
Thank you, Gwen. Given that, why is it so difficult to get data if you're just counting the number of transactions?
I think it's the granularity. Plans might have internal reports on their overall numbers of transactions, but not have it broken out by type, such as by mail versus fax versus phone versus electronic. And on both the provider and the plan side, we found that the respondents had to make some estimates of how much these transactions cost. That data, again, weren't necessarily at the very at their fingertips, and so they had to go through and estimate time and costs and so on. I hope that answers your question. Are there any other questions?
There are some questions that have been asked that I think are best directly replied to very specific questions. So I think at this time we will end the webinar. Again, we invite you to visit the CAQH.org website to view the entire report and also look at the fact sheets about how you can participate in the 2015 index and information on how you can contact us in the future. On behalf of CAQH, good afternoon. Thank you.